I would like to welcome to the stage Professor Paul Kolditz, the President of the Pediatrics and Child Health Division, to introduce the Howard Williams oration.
Thank you. It's my great pleasure as President of the Pediatrics and Child Health Division to introduce the Howard Williams Medal recipient and introduce his oration. And Sir Mason, it is probably about another interface, an interface between the past and the future, and how we all have an individual responsibility and opportunity to design a better future. Professor Lex Doyle is the recipient, and he is a neonatal paediatrician at the Royal Women's Hospital in Melbourne and at Melbourne University. He has made major contributions to the basis of modern neonatal intensive care, and particularly through its study of the graduates of neonatal intensive care and the impact of that through their life course and the economic consequences. His leadership of the Victorian Infant Collaborative Study, the VICS group, and more recently the Victorian Infant Brain Study, the VIBES group, has resulted in many papers over decades that, because of the comprehensiveness of the population-based studies that have been generated, receive attention in international top impact medical journals. It's because of that particular skill that he has contributed to many Australian randomised controlled trials to design the better future, but he's also been sought on the basis of those skills as a chief investigator for many multinational randomised controlled trials. So, Professor Lex Doyle, welcome to the stage to tell us about a career in neonatal research. Thank you.
Thank you very much, Paul. It's a huge honour to be here to give this oration today, and I hope to tell you a story that will help you understand what has happened over the course of modern neonatal intensive care. I was given an alternative title, which this title I don't like, so I like the first one better. But I need some help to tell you the story, and I'm going to show you a few pictures just to get you thinking. Some of those faces you may recognise, but more to come. Around the time I was born, if I'd been born very preterm, chances are the care for me would have been quite limited. I'd summarise it as the Spartan Approach. The Spartans used to put you on the mountain if you were still alive in a couple of days, but they thought you were pretty tough and worthy of being reared. And that's basically what happened in neonatal care. There was very little help for breathing. Probably would have been put in an incubator at a fixed temperature, and my body temperature probably would have been quite low, maybe 33 or 34 degrees, and I would have been thought to be a poikilotherm or a snake. And I wouldn't have been fed for a couple of days. That would have been the standard of care, and pink, warm and sweet is the holy trinity of looking after babies. It took me 30 years to learn that, those three simple words. Consequently, there were very few survivors who were very small or very immature. And the long-term outcomes for the few survivors there were very poor, and there were a series of papers written by Cecil Drillian from Edinburgh describing the outcome for babies under 3 pounds, still before the decimal system. And for those of you who don't know how much 3 pounds is, 1,361 grams. And the prognosis was really pretty grim. The commonest cause of death was respiratory distress caused by Harlem-Emra disease or surfactant deficiency. And there were some treatments available, and I'll just summarise those. Oxygen, ventilation came later, and surfactant came later. So what was the status of oxygen at that time? this is the first prop. This may be unrecognisable to you. When I showed this to my daughter, she said it's a kitchen cupboard on its side, and that's basically what it is. It was built in the garage of an engineer who worked at the Women's Hospital in the 1940s, but it's actually a transport incubator in which you can put a baby. That's not a real baby, you can be reassured, and you can run oxygen into it, and that was made in 1947. The thing about this incubator is it's got a couple of design features that you don't see on transport incubators today. It has actually spring suspension and pneumatic tyres, so the baby had a smooth ride. Contrast that with the supermarket trolley-type trolleys that ambulance people use today, bang, 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 bang. The babies all get severe traumatic brain injury today before they get to the hospital. But anyway, this was for moving babies around our hospital. Oxygen therapy had been around since the 1930s in some parts of the world, but by the 40s then, in America, they'd built special incubators and you could concentrate the oxygen up to around 60 to 70%. And the routine for babies under 1,500 grams was to put them in oxygen around 50% or more for at least the first 28 days of life. And then they started to see something strange, which was referred sarcastically to as the Boston disease, because that's where it was reported. That was the part of the world where they had oxygen first. And this was basically children coming back several months after they'd been born with detached retinas. We call it retinopathy of prematurity today. But why did they give oxygen? Well, it's because the babies behaved better. It reduced what's called periodic breathing. Preterm babies tend to breathe quickly, stop, breathe quickly, stop. You can see the gaps in the breathing here. These are all pauses for a number of seconds. You put them in oxygen, the pauses go away. So they were better behaved. So yeah, give them oxygen. Then we don't have to worry about them so much. That was the attitude. The late 1940s, the NHS was introduced in Britain, and all of a sudden they saw RLF for the first time, retrolental fibroplasia. And Mary Cross in Birmingham speculated oxygen might have been the cause, which leads me to this picture. This lady is Dame Kate Campbell, the first paediatrician at the Royal Women's Hospital in Melbourne. And in 1951, she wrote an article in the Medical Journal of Australia with this title. And she wrote in it, "I heard from colleagues returning from overseas the suggestion that oxygen might be responsible for causing retrolental fibroplasia." Kate worked in 3 hospitals, and one could afford oxygen, and its rate of retrolental fibroplasia was 19%. The other 2 had to restrict it. They couldn't afford it. They had to give it only in dire need, and their rate of retrolental fibroplasia was only 7%. So this was a suggestion oxygen might be contributing. Which leads me to this gentleman, who is Bill Silverman, and any paediatricians in the audience must read this book, which he wrote in the 1980s. It's available, you can download it on the web because it's out of press, but it's a wonderful story of the early days of neonatal intensive care in New York. But Bill was involved in a subsequent randomised controlled trial of routine versus curtailed oxygen, where you would only give oxygen if needed and keep it below 50% rather than the routine of more than 50% for 28 days. Now, they restricted this to babies up to 1,500 grams, but they had to live 48 hours or more to get into the trial. And they wanted to look at the competing risks of blindness versus death or brain injury. So the sort of trial you might design today, you want to know the long-term effects of the treatment you're doing rather than just short-term things. That's what they said they were going to do. Now, they started in 1953, and over the first 3 months, they randomly allocated in a 1-to-2 ratio. So that tells you they thought the oxygen was the problem, because they wanted to limit the number of babies who actually got unlimited oxygen. And then after the first 9 months, if there wasn't a difference in mortality, then everyone got the curtailed group. So they end up with a sample size that looks quite weird. If you were to design this trial and ask for funding for it, you'd be laughed out of the room. But that's what they did. And of course, the ratio is quite different between both singletons and multiples. It's quite out of whack. And of course, the rate of scarring retrolental fibroplasia was much higher in the routine oxygen group. Everyone interpreted this to restrict oxygen big time, and this ended the epidemic of retrolental fibroplasia, which had been running for about 10 years and caused about at least 10,000 babies in America to go blind, and one of whom was Stevie Wonder. If you ever wonder why he was blind, that's why he went blind. He was born in 1951. This led to the era of oxygen restriction. Now, you can probably guess what happened when they limited oxygen. The babies who really needed it, who were struggling to breathe from a lack of surfactant, didn't get enough, and their mortality rate jumped up. And they forgot that in the randomised controlled trial, all those babies were already dead. They never got into the trial because it kills you pretty quickly, generally. So, oxygen was limited and restricted. You can't give more oxygen, the baby will go blind. But the baby's dying from lack of oxygen. So, a circular argument that was never resolved. And it was estimated there were at least 16 deaths for every case of blindness prevented. And the other thing that happened was, in those survivors who did make it, cerebral palsy rates rose. The cooperative trial was going to follow up those babies, but it never happened. Why? Because the trial was run by eye doctors. These are surgeons. Surgeons don't think. They think of the surgical target and the rest of the patient forget. So that's what happened. With technology, we were able to start measuring arterial PO2, but you had to get an arterial sample. That was the trick. And from the 70s, you could actually measure PO2 transcutaneously with a really neat machine, but you had to move it around because it would burn the skin after a couple of hours. And then the ubiquitous oximeter started to appear in the later 80s, and by the 90s, every baby was on an oximeter forever, including going to school. I'm being sarcastic. Arterial PO2 and transcutaneous PO2 really were measured quite less frequently, and the oximeter replaced all that. Bill Silverman, the same guy I showed you before, 40 years later wrote this: put it bluntly, there's never been a shred of convincing evidence to guide limits for the rational use of supplemental oxygen in the care of extremely premature babies. Bill died a year or so after that. Anyway, we thought we'd better try to do something about this in Australia, and so we got some funding from the NHMRC to do a randomised controlled trial of comparing different oxygen targets, 85 to 89% versus 91 to 95%. And there were 4 other similar trials around the world: New Zealand, Canada, USA and UK. And this was a world first for neonatology because all the trialists got together and said, well, we're going to do these trials, let's pool the data and do a prospective individual participant data meta-analysis. And the results of that were published in JAMA last year. So ultimately there were 5 randomised controlled trials, nearly 5,000 babies. You would think after that we'd have a clear idea of what we're doing. What did we show? The restricted oxygen, yes, reduces ROP, that's retinopathy prematurity requiring treatment. That was the primary endpoint of these individual trials. Well, sorry, it was one of the endpoints of these individual trials. But it didn't have an effect on blindness when the children were followed. And the mortality rate was higher in the lower oxygen group. And the major outcome, I should have said this is the major outcome, was death or major disability at 18 to 24 months. Was not reduced, in fact was slightly higher in the lower target group. Now it looks like death has trumped ROP, and most people have gone back to now monitoring the higher level rather than the lower level. In 2019, do we really know how and when to give oxygen, how and when to monitor oxygen therapy, and the correct saturation range to target? I don't think so. And do we know how to treat ROP? Because what's happened is we've seen the introduction of this drug, bevacizumab, an anti-cancer drug. It stops blood vessels growing because one of the features of retinopathy prematurity is aberrant blood vessel growth in the eye, and the aberrant vessels clot up, scar up and cause detachment of the retina. So you'd think this would be good treatment. And what's happened is on the basis of this evidence, randomised trial published in the New England Journal 8 years ago, babies under 1,500 grams or less than 30 weeks with stage 3, which is getting worse. And the primary outcome was recurrence of retinopathy prematurity requiring treatment. They were randomly allocated to this stuff, which is injected into the eyeball, and the rate of the primary outcome was 4%. And note the denominator is eyes, not people. And laser therapy, higher rate, that was the standard care, higher rate of retinopathy requiring more treatment. Again, the denominator is eyes. PUAU or magical, everyone's convinced that's why it gets in the New England Journal. But there are a couple of other things here. Death rate, higher if you get injected with this stuff. Now, not statistically significant, but I don't want to be one of the 5 babies who's died. And you can see the total sample size is only 150 total. The other thing is, long-term neurodevelopment, what they like long-term, has only been reported on 16 children. And that's the total evidence on which we are injecting little babies' eyeballs today. This stuff gets out of the eyeball into the circulation, and babies are characterised by growth. And to have growth, you need blood vessels. And if you're going to make blood vessels not grow in other parts of the body aren't going to develop properly. And think brain here. But this is what we're doing. History is definitely being repeated here. And of course, this is an eye doctor study. It's really quite crazy. Anyway, now there's at least one observational study telling us that bevacizumab is possibly worse. So we need to be worried about this as baby doctors. What about ventilation? It wouldn't have been available when I was born. And adult ventilators started to be introduced in the 1960s as a last resort in babies who were almost dead, and so therefore the outcomes were pretty dismal. And one of my senior colleagues referred to them as the work of the devil. In other words, he didn't like them at all. In the 70s, baby ventilators were developed, and they started to be used a little bit earlier in the course of the disease, but the survival rates rose just a little. And if I just show you some survival data for babies under 1,500 grams in yellow or under a kilo in aqua from the Women's Hospital in the 60s, around 6% of the under 1,000 gram babies survived, and about a third of the under 1,500 grams. And this is before ventilation. When we introduced the ventilators, this is the days of ventilation. 1971 was the first baby ventilator, and it started to rise. Did the survival rate increase? Well, not a whole lot. You can see there's just a little bit of an increase there. But then, of course, we used ventilators more and more, and these are mean days of ventilation in green. And then we started to introduce other techniques, nasal CPAP and high-frequency oscillation up the top. And you can see that a lot of increased consumptive resource, and then the survival rates look like they're going up. But there are a couple of other things happening in the background here. And one of these relate to surfactant. And I just want to pose the question to you, why is surfactant important? It's because everyone in this room has been affected by a lack of surfactant. Did you all have hyaline membrane disease and lack of surfactant? No, I don't mean that. I'll tell you why. It relates to these two guys. I think they're recognisable to you, at least the guy on the right, probably recognisable to everyone, John F. Kennedy. Bob Hawke, still alive, but was Prime Minister of Australia at one stage, and of course JFK, leader of the Western world, basically. But these two men have lots in common. They were womanisers, very handsome, have lots of hair, about which I'm very jealous. But they're also linked by August 1963. And I have to put this in chronological order because the date is the 1st of August 1963. Bob Hawke had a son, or his wife had the son, he was involved, at 33 weeks gestation. This is only 7 weeks early for you adult physicians. You don't know that 40 weeks is the usual duration of pregnancy. And he died after 4 days from respiratory distress, which was almost certainly caused by a surfactant deficiency. And then just 6 days later, in northeast of America, Patrick Bouvier Kennedy at 34 weeks gestation was born, and he had respiratory distress and he lived only 39 hours, almost certainly surfactant deficiency. They tried hyperbaric oxygen. They had a ventilator, but they were too scared to use it, basically, and he died. So it's almost impossible to die from surfactant deficiency today at 33 and 34 weeks. It just doesn't happen. We've got too many tricks up our sleeve. And of course, what happened just over 3 months later? I think everyone pretty much knows this. JFK was killed. Now, almost certainly he would never have been in Dallas if his little baby son hadn't delivered 3 months earlier. You've seen the movies, Babel, sliding doors, how things change. And of course, world history was changed forever by a lack of surfactant. And what do I mean, how it's affected you? We don't have these guys in charge. We have these guys in charge. We've all been affected by lack of surfactant. Just think about that. Which leads me to this gentleman. To me, he's a New Zealand hero. And he's Montlegans. I think all the New Zealanders probably know him, but perhaps a lot of you don't. But he is an obstetrician. And he was using corticosteroids to induce preterm labour in sheep because he was interested in the onset of labour. And he noticed that the preterm lambs who were delivered after their mothers had been given corticosteroids had stable lungs and they didn't die from breathing difficulty. And so we thought, well, why don't we try this in humans? So with his paediatric colleague Ross Howie in this city, they designed the first randomised trial of neonatal corticosteroids, first published in 1972 and ignored by certainly the Northern Hemisphere for at least 20 years beyond that date, but picked up a little bit across the ditch a little bit earlier, which I'll tell you about in a minute. But if you want to show the evidence for why corticosteroids are good, this is the blobogram or forest plot from the Cochrane database. If anything is to the left of the line, that's a reduction in mortality. And overall, there's clearly a reduction in mortality. You won't be able to read the numbers, but you reduce mortality by a bit over 30%. Interestingly, the original Liggins trial, when they published the full results a number of years later, didn't actually show a reduction in mortality. They showed a reduction in respiratory distress syndrome or hypomembrane disease, but not an increase in the survival rate, which is perhaps most of you don't realise that. Which brings me to this gentleman who was across the ditch and professor of obstetrics and gynaecology at my hospital when I was working there in 1978, and he did a randomised trial of corticosteroids. And why do I mention this? I was the mug who had to collect all the neonatal data for him, and I used a spreadsheet. Now you think, when I explained this to my daughter, she said, well, did you use Excel, Dad? I said, hang on. 1978, give me a break. This was a proper spreadsheet. It would have spread across the whole stage. I had to get down on my knees and write down everything across the paper. And that was wrapped up and kept, and it ended up being a total of something like 500 women, I think, ended up in that trial. Which brings me to exogenous surfactant. In terms of therapy, you can give it prophylactically, you can give it after they're sick, you can give biological variations, you can give artificial variations of surfactant, and basically surfactant is good stuff. And we've had that available from March 1991 in Australia. And if I go back to the survival rates that I showed you earlier, it wasn't just ventilation that was contributing to the increase in survival, because by the late 70s we were using corticosteroids. This was around the time Roger Pepperell was doing his trial, and when he completed it, then we started to use them more routinely. And we were certainly more enlightened than other parts of the world. And surfactant came along in 1991. So you can see how these things, all interwoven, were responsible for improving the survival rate. So what's happened since the early 90s, between 1991 and 92 and 2005, we've had more and better surfactant. So the outcomes should get better, right? Well, the answer is no, they don't. What we've shown is that we've had increasing consumption of resources for both ventilation and oxygen, and increased oxygen dependency long-term at 36 weeks post-menstrual age, and worse respiratory airflow at 8 years of age. So you adult respiratory physicians, you're going to start seeing these kids as adults. They're going to present to you with obstruction or symptoms of chronic obstructive pulmonary disease in adulthood. So you need to be aware they're coming in big numbers, I can tell you. We've had more non-invasive ventilation since 2005, including something called nasal high flows appeared on. It's better than sliced bread, so everyone's using it. Are the babies any better off? I don't think so, but I can't show you data today. We're collecting those data, and we think they're worse off rather than better. What about other long-term outcomes? This is the next picture. This gentleman is Bill Kitchen, and he was my mentor when I first started in neonatal paediatrics. And he's the 5th Howard Williams medalist. He did the first ever trial of intensive care in Australia at the Women's Hospital in the late 60s. And intensive care wasn't ventilation, it was the ability to measure PO2, as I explained before, infuse glucose to stop them getting hypoglycemic, remember they were starved, and infuse bicarbonate, which you might think is strange, but it was designed to reverse acidosis and had been shown to be useful. But he confined his trial just to the bigger of the smallest babies, from 1,000 to 1,500, because the under kilogram were thought not to be worthy of treatment. And he showed this package would increase survival, but because he followed them up, he showed that the extra survivors had a higher rate of what he called handicap. He had a limited viewpoint just working in one hospital, but he had the wisdom to seek out his colleagues in the state, and this led to the formation of the Victorian Infant Collaborative Study Group. And we've had a number of cohorts from the late 70s, but these 3 cohorts born in the 90s and then 2005, just to give you a flavour of what the sort of things we do is, to give you some idea of what the disability rates are. If we think of major problems with thinking, hearing, seeing, walking or talking at 8 years of age, these are things that you don't want your children to have. What are the rates in these extremely preterm infants? And technically, these are the descriptions, but I won't bore you with the technical details. And we see most of these kids at follow-up. And here's the rate of survival with major disability. It's 1 out of 2 in 22 weekers if you're born that early. And you can see how it drops, the major disability drops with increasing gestational age. So you can see why we're very keen to keep these babies in the uterus if we possibly can to get them more mature. The overall rate is about 17%, which is about 1 in 6. Now you look at that and you think, these people are crazy. They're producing heaps and heaps of disabled children. Well, you've got to remember they're always compared with something else. We always have control groups, and 2 to 3% of controls have major problems with thinking, hearing, seeing, walking or talking. And if we think of that total number, are we flooding our resources with disabled children? In the state of Victoria, about 200 extremely preterm live births occur each year, and 75% will survive, and 17% have major disability. The total number will be 26. Compared with term children, 72,000 births in 2017 who were born at term, virtually all survive. Even if we take the lower rate of 2%, that's 1,437. That's a ratio of more than 50 to 1. And if you can't see the numbers, here it is graphically. Where are all the disabled kids? They're born on time, they're not born extremely preterm. So I've told you about the worsening lung function. What about other outcomes? Academic progress, motor function, executive function, how the brain organises itself. There are a number of publications over the last couple of years. These are all getting worse over time. We're not getting better. So that's the sort of technical side of the talk. What about the personal side? Well, a measure of research output is publications. It's not the only measure, but it is a measure. And if you search my name with a wildcard character for the middle name, this is what you come up with. And you won't be able to see this, but this starts at 1920. Now, I'm very old, but I'm not that old. So that's not all me, not all down to me. But my life starts here, 1949. I grew up in inner city Melbourne, and I went to primary school, the local state primary school, and I skipped a year along with a couple of colleagues from grades 1 to 2 because of class sizes. And so I had 6 years of primary schooling and 6 years of secondary schooling. And then I went to medical school. Which brings me to this character. Does anyone know who this is? Anyone old enough to remember? It's Bob Menzies, Prime Minister of Australia twice. But the second time, from the first year I was born, he was Prime Minister, the only Prime Minister I knew through my childhood. But his government introduced Commonwealth scholarships, which enabled me to go to high school for a start, and secondly to go to university. Without those scholarships, I wouldn't be standing here today. And why did I pick medicine when I got to the end of high school? I really wanted to be a weatherman because I wanted to go to Antarctica as a kid. I had this dream I wanted to go to Antarctica. I must have read about Scott of the Antarctic or something. But when I saw 6 years, I thought that's good enough for me. I was immature. I just wanted to stay at school because I love school. So that's why I did medicine. So that's serendipitous. Then I did an intern year and then started my pediatric training. And I'll just give you a little bit of background to that. I trained at the Royal Children's Hospital, which involved a rotation at the Royal Women's Hospital on a couple of occasions. And my neonatal exposures were firstly as a junior, well, not as a junior RMO because we didn't have neonates, but as a registrar the following year. My first rotation was in haematology, and I had to cover the neonatal unit at the Royal Children's Hospital on weekends. I'd never seen a neonate really before, and that was pretty scary. And that first weekend coincided with this meeting when it was called the Australian College of Paediatrics, which meant all the neonatal paediatricians were out of town, except for one, who was covering virtually every other unit. So I had a lot of backup there. I then went, the next rotation was 4 months to the Royal Women's Hospital. And here I was one of 2 RCH registrars on rotation along with a fellow, and I was responsible for 40% of the public babies. We had 100 babies in the nursery, and the normal babies stayed in for a week or 10 days if they were delivered by a caesarean section. They were nursed in a communal nursery. And what does this mean? There was a rotavirus epidemic. We didn't know it was rotavirus then, but this rotavirus is very important because rotavirus was discovered in the faeces of babies from our nursery around this time by Ruth Bishop and Graham Barnes at the time. And the original strain is currently used in a vaccine that's responsible for reducing deaths worldwide. And we're going to hear more about that tomorrow. At the time, we had 3 ventilators called Lusco, little square boxes that had an on-off switch, and that's all I knew how to run. And there was one machine that no one really knew how to use, and that was invariably lethal if we used it. And we found out later that the dial was about 10 centimetres of water too low. So when we thought it was 5 centimetres, it was 15. So that's why we were causing problems. But we thought square wave ventilation was good. We couldn't achieve it with those ventilators, but we ended up producing massive air leaks, and air went into strange places, not just pneumothorax and into the lung or mediastinum, but into the neck, the scrotum. I think I'm probably the only person who felt crepitus in the scrotum. Seriously into the pericardium, where you just turn white, and air embolism, which is obviously fatal. And I've seen a number of air angiograms, air in the heart and great vessels, so that's pretty bad. The hours I worked, this is the roster. I'll come back to that, why that's important, but it was a lot. I managed to pass the exam the following year. I had a level 2 rotation before NETS was in place, which meant I was in the back of the ambulance a number of times, ventilating babies by hand, staring around corners and running through stoplights, hoping to hell none of us would die. And then I went to the Children's Hospital for 4 months, no ventilators, and I was advised not to do neonatology by a senior mentor, and I ignored that advice. I went back for a whole year to the women's as what would then be the fellow. And there were more of us, and we had a director, we had proper ventilators, and things started to improve. But I still worked lots of hours. And one of those was working for NETS on Fridays, and invariably I get at least one long trip. And I did the 1000th NET trip, and I did the first international NETS trip. And forever the NETS nurses wouldn't speak to me because the NETS nurses couldn't come on the trip, so I was in the bad books. Nothing to do with me. This gentleman is in the audience, I'm pleased to say. Graham Barnes, the gastroenterologist at the Children's and the 19th Howard Williams medalist, came to Bill Kitchen and I and said, well, I've just been reading this study on no-thoracic lambs that oral gamma globulin prevents rotavirus diarrhoea. So Graham set up a randomized controlled trial which was published in The Lancet, and sure enough, oral gamma globulin does prevent rotavirus diarrhoea. I'll skip the anecdotes because otherwise we'll go over time. I then went to McMaster, different ventilators, different way of ventilation. Basically, we were slave labour for the Canadians. Canadians didn't want to work in neonatal intensive care. It was too hard for them. I did do an MSc while I was there, and I was taught by this guy, Jack Sinclair, the father of neonatology in Australia, because by the late 80s, about half the neonatologists working had been working at McMaster. And he taught me by not teaching me. McMaster had a philosophy of problem-based self-directed learning. I hardly ever saw Jack, he was never in town, but I solved all the problems myself. I worked on a machine to measure insensible water loss, which was all metal, and all the data on insensible water loss is wrong because metal expands and contracts when you change the thermal environment. And I tried some PET scanning of baby brains, which is a story for another day. I came back to Melbourne, and where I've been ever since, with 2 masters, the university and the hospital. Laurie Merton was still there, and we still had the same machines, but we had more house staff now, so the hours worked were reducing. And we also got a different machine later on. Laurie died in 1993, which meant more clinical work for me, less time for research. And a guy called Colin Morley came later in the 90s with ideas for different ventilators, different way of ventilating. He bought a new machine. It had too many knobs for me. I had to resign from clinical work in 2006. It was getting too hard. I just didn't have time to concentrate on the new ways of doing running the machines. But what about my research career? I designed 2 large randomised trials. One was to restrict fluid to prevent lung injury in preterm babies in the 80s, and that couldn't be done because by the time I came back to do that trial, everyone was getting fluid restriction. And the other trial I designed, if gamma globulin prevents rotavirus, it might prevent NEC. This was 1983, and we had to withdraw it at an interview because by that stage it was clear there was something in blood doing bad things. That something turned out to be HIV. And I'm really glad we withdrew that application because I think we might have got funded, and it would have been a disaster if we'd used a multi-donor blood product in little babies giving them HIV. So my research career was clearly struggling. If I go back to this diagram and show you the correct data. First publication, 1979. Clinical training, I think you'll agree with the hours I was working. You would say this is relative to opportunity. I didn't have any time to do any research. And then I struggled in the first few years, and when I got back to McMaster, back from McMaster, Bill saw I was struggling and started to feed me a few crumbs of data. So I started working with Bill and started to produce more publications. Laurie died, Bill resigned, Laurie died, and then I formed an alliance with this lady, Caroline Crowther, who's an obstetrician currently working in Auckland, as it turns out. But she was interested in antenatal interventions designed to improve long-term outcome, and one of those was magnesium sulfate, which today we know reduces cerebral palsy. So this is how my publication career has developed over time, and when I stopped working clinically, you can see it went up even more. And not only that I publish, but people read what we produce, basically. So what are the challenges for the next generation? Remember history. Oxygen is a mess. Treatment of RAP is heading down the wrong path. What are we doing to the lungs of these tiny babies? And we clearly need to improve long-term outcomes, but we're going the wrong way. You need to find time for research, and you need support from your administrators, and you need to learn to say no. It will make you unpopular, but you can't do everything. Concentrate on what's important. So how do you do research? You ask answerable questions using a PICO structure. You need persistence and patience. Without those two qualities, I wouldn't be here. And you need plenty of friends. It took me a long time to realise this. You can't do stuff by yourself. And the real reason why you need plenty of friends, they do all the work. That's the trick. You get all the credit, they do all the work. Research will help you sometime one day, and my research has helped me personally in a way that I won't describe at this meeting. So how did I get here? With the help of all these people and all these people. And if you are on an NHMRC grant panel and you see these people's names, please give them 7s. Don't give them 6s and 5s and 4s. They won't get funded. The research needs to continue. Thank you for your attention.